General of Health Services, Ministry of Health and Family Welfare, I warmly welcome you all to today's session under the National Capacity Building Program on Patient Safety in India. We are delighted to continue this important journey of knowledge sharing and system strengthening through these webinars, which bring together experts and practitioners from across the country. Today's session will focus on a very pertinent topic: Patient Safety Index and Patient Safety Surveillance System for Tertiary Care Hospital. We are fortunate to have with us Dr. Smita Sinha, Additional Professor at AIMS Rishikesh, as our session expert. Before we begin it is my privilege to invite Dr. Sujata Chaudhary, Additional Director General of Health Services, Ministry of Health and Family Welfare, to deliver the keynote address and set the context for today's discussion. Over to you, ma'am.
Ma'am, you have to unmute yourself actually. We are not able to listen you.
Yes.
Yes, sorry for the interruption. Could you please repeat
Yes.
once again, ma'am? Thank you.
Okay. Good afternoon, everyone. I bring greetings from the National Patient Safety Secretariat, Ministry of Health and Family Welfare, to all AIMS patient safety nodal officers and faculty from medical colleges, hospitals, residents, nurses, and other healthcare professionals. I welcome you all to the 15th webinar of the National Capacity Building Program on patient safety. So today's focus will be on Patient Safety Index and Patient Safety Surveillance System for tertiary care hospitals. Ensuring patient safety is the core component of high quality healthcare. However, healthcare institutions often lack standardized tools to measure as well as monitor the patient safety performance in a structured and objective way. Patient Safety Index or PSI is a composite tool that, that aggregates various indicators of safety, enabling healthcare facilities to benchmark, monitor, and improve their safety practices. This includes key safety domains such as medication safety, surgical safety, healthcare associated infections, pressure ulcers, fall prevention, hand hygiene, communication, patient identification, and adverse event reporting. So the PSI or Patient Safety Index facilitates the data-driven decision making, helping institutions to track their progress over time and identify the priority areas for improvement. The patient safety surveillance system supports tracking of safety incidents such as adverse events, near misses, sentinel events, and system vulnerabilities using structured tools like incident reporting forms, dashboard, and root cause analysis. A robust surveillance mechanism is essential to detect patterns, evaluate the effectiveness of interventions, and foster a culture of learning and accountability. Now, tertiary care hospitals, being referral centers and academic institutions, have a crucial role in implementing and institutionalizing these systems. So, establishing dedicated patient safety committees, assigning trained nodal officers, conducting regular audits and M&M meetings, and engaging all healthcare staff are key steps in this direction. So, one of the biggest challenges is underreporting. So, which is often due to the fear of blame. So, we should build a non-punitive environment where reporting is encouraged as a tool for improvement in the fundamental. Leadership, commitment, ongoing staff, sensitization, and integration of safety surveillance with electronic health system can go a long way in ensuring sustainability. Also, developing and adopting a national level PSI framework which is customized to Indian tertiary care settings, will help to create a unified approach to safety, benchmarking, and policy formulation. To delve deeper into this important subject, we are pleased to welcome Dr. Smita Sinha, who is additional professor at Department of Community and Family Medicine, AIMS, Rishikesh. With her expertise in community health system and quality improvement, she will share practical insights on designing and implementing patient safety index and surveillance systems in large hospitals. Let's continue working together and towards building transparent, accountable, and patient-centered healthcare systems. Thank you for your dedication, and we look forward to an engaging and enriching session. Well, over to you, Dr. Smita Sinha. Welcome.
Thank you, ma'am. Good afternoon, one and all. Before I'll proceed, actually, I'm very pleased to be part of this ongoing webinar series conducted by Patient Safety Secretariat at Ministry of Health and Family Welfare. Actually, the topic which was today given to me is Patient Safety Index and Patient Safety Surveillance System at Tertiary Care Hospital, and most of the things that you have already told, madam. So I'll just share what we are actually experiencing here. So before I'll begin, I'll just so next slide, please. So before I'll begin, because this is an ongoing thing and we all are aware of what patient safety is all about. So I'll just briefly touch upon the topic again. So patient safety, as we all of us know, that it is defined by WHO as the absence of preventable harm to the patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. So this the data which I have quoted is that around 1 in every 10 patients is harmed in healthcare. More than 3 million deaths occur annually due to unsafe care, and in low and middle income countries is as many as 4 in 100 people die from unsafe care, and around the 50% of these harms are preventable. Actually, the most quoted data about patient safety, and this is actually gives us the global picture of what is actually the harm, the extent of harm which is happening due to unsafe practices or the error committed because of many reasons. So next slide, please. Next one, yes. So we have, what we know about patient safety in India is actually a big question. So it's not that we are ignorant. We do know that patients are being harmed at our hospital across India, but the most of the time the data we are coming across by the few of the published scientific research, few of the reports we come across, and many of the time may not be that robust or reliable, you can say, but definitely the media is also one of the way of letting us know that yes, there are harm being done at healthcare facility also. So to take any action, we need to have a baseline data, and we all agree to it that we have very limited data, even at a district, state, or a national level. We come across the scientific published research or a few of the reports also, but most of the time it is in one particular domain or may not for the at the national level or state level. So we are also taking implementing multiple programs for patient safety or minimize harm, because it is definitely not a new thing, but definitely it deserves a new momentum to ensure patient safety. So there are programs like National Guidelines for Infection Prevention and Control in Healthcare Facilities, AEFI, NSI. The ADR is there, Adverse Drug Reaction Reporting under the Pharmacovigilance Program of India. The blood safety too. These are few of them I have noted, and I have left few of them also. So this is only to give a picture of that we are doing implementing some programs for patient safety. So what is new about it? So next slide, please. So the problem here is whatever implementation or program implementation we are doing is the major limitation is that whatever we are doing is every program is working in isolation, and whatever efforts we are taking are actually fragmented, and many of the time even those are not giving any fruitful results. One of the major challenges is the suboptimal implementation across India. Like not everyone, even I will give the example of hospital infection control initiative, healthcare associated to minimize healthcare associated infections. even each component is not being implemented in one particular institute. Like few of them are actually focusing on hand hygiene, few of them are focusing on the process of hand hygiene, few of them are actually focusing only the 5 moments of hand hygiene. So even one particular program is not being implemented in one institute also. So this is one of the problem with the individual program. There's a variation between at a institute level, at a district level, as well as a state level. So estimation of overall patient safety, even if we are concerned with one particular domain, we are not able to gain something which is to make a dent for or we can claim that we are doing enough for patient safety. So we need to do a lot about it. Next slide, please. So till now, as I have enumerated few of the patient safety program or initiative undertaken by Government of India, most of them are actually giving an idea about one particular indicator or one particular domain of patient safety. So so it is a high time that we should shift from indicator to index, because index is always it gives an idea of it gives a composite score that summarizes data from multiple indicators, and it gives an overall picture of any health status. In this particular time, we are talking about patient safety. So giving or getting information in single score is far easier to communicate also between us with for any advocacy purpose or any decision making or even for quantification. It is far easier to visualize the phenomenon by one particular index, and it is easy to look into the matter in a multidimensional way. So next slide, please. So it is well documented. We all know that indicator and versus index. So what we should rely on. So it is well designed index can provide a comprehensive vision of a multidimensional phenomenon. Definitely, patient safety is a multidimensional phenomenon, and it allows for setting of national benchmark, which is at present we don't have, and for further international comparisons, and is a starting point of analysis and discussion. So next slide, please. So what is patient safety index is actually what we can do about it. So now we have indicators, and we are trying to move from indicator to index. So how can we go about it? We can actually pick up the indicators from already existing patient safety interventions or the program. They can be combined together, and we can agree to it, and because it needs a lot of work, which indicator will be picked up, which need to be validated, how much variation in the outcome will be explained by this one particular indicator. So there is a lot of work which goes into when we try to build up a patient safety index. So we do have indicators, so that is a one good thing. We need not to start from the scratch. But once we will be able to finalize the patient safety index, so it will provide the opportunity for quantifying, as I have already explained, the patient safety by a single score. That will be actually a very easy for managerial, for programmatic purposes. Uniformity in monitoring and evaluation can be achieved. The problem with monitoring and evaluation is most of the time is we need an objective criteria for that. If the more subjectivity is there, the more variations will be there, and it will be very hard to compare between even in the same setup across the time point. It will be very hard to compare the data. If we are standing today at 50, so if we have to go at 60, so if it is far easier to do or to assume or to aspire than just going in a subjective manner. This is good, I have to go to excellent. So apart from that, this patient safety index will actually help us to compare also across the health system, because it being an index, it will have all the benefits of an index, of any kind of index which we develop for that particular purpose. And definitely it will be easier for advocacy purposes also. So next slide, please. So as explained earlier, so we can think of taking taking variables or indicators from all this patient safety initiative which is already in place. So this ADR, AEFI, hospital healthcare associated infection, needle stick injury, blood safety, biomedical waste management, safe childbirth, antimicrobial resistance, to name a few. So next slide, please. So next slide, please. So from these programs, we can agree, we can brainstorm, and we can think of what all variable has to be included. Like we can take from adverse drug reporting, we can take how many incidents of ADR is actually is there. What is the for AEFI? What is the reporting status? Because many of the time in AEFI, the fatal incidents are being reported, not the minor ones. So reporting status we can think of including, and what is the extent of those adverse events. For healthcare associated infection, we can take like as already proposed in the patient safety implementation framework by Government of India, is the status of hepatitis B vaccination among healthcare workers, and what is the proportion of healthcare workers practicing hand hygiene. To begin with, these are the few things which will be easier to look for. Then how much the institute, that particular tertiary healthcare, is adherent to the protocol of managing biomedical wastes. What is the status of reporting and availability of post-exposure prophylaxis? So this is again because many of the time reporting is as a problem when needle stick injury happens. Let me share you one incident happened at our own institute. We usually take our UG students to field, और एक स्टूडेंट ने कुछ usually MBBS are not allowed to actually do any kind of because they are second year, third year students, so they are not allowed to do blood testing or any by glucometer or anything. But one student was thoda overexcited and he said ki like I'll do, and MSW was there, so she was new and she was not aware कि क्या करना है, इसको देना है या नहीं, एंड उसका प्रिक हो गया. सो अब उस प्रॉब्लम एक्चुअली ये थी कि ही वाज अ बिट कंसर्न कि मैडम को पता चलेगा तो मुझे बहुत डांट पड़ेगी. सो यहाँ पे यूजुअल पेशेंट से थोड़ा डिफरेंट है या हेल्थ केयर प्रोफेशन से. सो ही वाज ट्राइंग वेरी हार्ड कि इसको नहीं, आप बताना नहीं मैडम को कि मैंने किया और मेरा प्रिक हो गया. So then I came to realize that we always think about needle stick injury of patient, attendant or a doctor, but इस सिनेरियो में हमने कभी नहीं सोचा कि इसमें भी एक चैलेंज आ सकता है एक नहीं बताने का. यूजुअली अवेयरनेस नहीं है, then it is okay. So needle stick injury reporting is actually very, very important, and if it is being reported, what is being done? Is there any facility for that? Most of the time at our institute what happens is immunoglobulins अगर हुआ है hepatitis का titer उसका low आ रहा है, immunoglobulin देना है, most of the time it is a challenge. So a lot of resources are also required apart from SOPs and training of personals. So that can be taken as one of the things. The LAKSH certification of institute or a healthcare facility can be considered for making a composite index. Blood safety is also an important thing, like adherence to transfusion protocol is there in they are following any of the American or New York or like, because here also they have made their own by visiting many protocols. So at least there's one transfusion protocols which is being followed, and it is supposed to. So So till now, what we have discussed is we have indicators. We need to move from indicator to index, and we can pick up few of the indicators and make a index which can give a value. So for how to get those value for combining or making those index. So definitely, for any data to get any data, we have to have a very robust patient safety safety surveillance system. And for this particular, we will need to have a patient safety surveillance system. So the first is, if it is not there, we need to establish it. If it is already there, and then we have to go back and look sincerely whether it is working optimally or it needs some strengthening. So we need to strengthen that. Until and unless we will establish or strengthen our surveillance system, we will not be able to get what is the magnitude and what are the causes of harm which is being done at our own institutes. So it is actually to how to begin to do it is, when if we have not yet established the patient safety surveillance system, then what we can do is we can start with patient safety incident reporting thing. We can go with a conventional way, the hard copy ones, or the form, the pro forma filling things. And or we can, if we have the resources, it is definitely in today's era, it will be far better to go in a digital mode. So that will be easy to do, and compiling and analysis and everything. So in this way, if we will be able to improve the incident reporting, so it will help us to document, which is often missed many of the time because of so many reasons, apart from fear that there was no one whom to, people were not aware whom to report. Like many for hospital control, many of the people even in our institute don't know that it is the micro people who are taking care part of hepatitis B infection. Most of the time they get confused that, because I am like CFM is running the yellow fever thing, so maybe definitely we are also actually running the hepatitis B vaccination of healthcare professionals. So that will actually, if we will improve that reporting system, we'll be able to document it. And to begin with, we should be actually very reasonable in our aspirations, because if we will improve the reporting, then it will not be reviewed and investigated, then the whole like the use of just wastage of resources, or the whole exercise is actually defeated. But if we will be able to do that, so we'll be able to redesign the process of care, product, and procedures. And it will definitely help to change the working practices and style of individual as well as team. Now here again, this is one challenge which all of us can foresee, is that most of the time when the feedback comes, people tend to take it's a kind of blame thing. So no, so hand hygiene was not being done because sanitizer is not being supplied. So this is, so many things are there. So take a corrective action. We all have to be actually in, not in that hierarchy system or a blame game. Next slide, please. So definitely, we will all agree that patient safety surveillance is a need of our. We have to have a surveillance unit for patient safety at our tertiary care institute, and we need to link all the ongoing programs, like at AIMS Rishikesh. At least this pharmacovigilance program is in place. This healthcare associated infection, this is also being done. Antimicrobial is in place, NSI is there, this biomedical waste management is there. But what I can see is that everyone is working on their own and taking corrective action at their own level. So we need to link all this program And to begin with, how to how to collect those data for patient safety. So there is already the pro forma for monitoring of patient safety was developed in 2010, long back at by the Ministry of Health and Family Welfare workshop. So that can also be used for monitoring purpose of this patient safety. To increase the reporting or to come up with this improved surveillance system, we can think of giving some kind of like incentive or reimbursement, as CDC has reported that it works in many of the hospital in US. And quality certification can also be linked to this based on the reporting done by the different institutes. So there's one another aspect to it is also we can also try to explore the legal framework on instrument. Next slide, please. Next slide, please. So what are the challenges we are actually which we can think of at for implementation of this surveillance system is creation of quality culture. So many of the time is actually the safety or quality is actually one cannot ensure without providing a safe care. So this has to be a focus area, and we all have to be committed to do this. And it should not be by any it should not be like hierarchy based. If someone is giving some suggestions or something, it should not be taken as how a junior can suggest me. So जैसे कहते हैं ना, सीखने के लिए कि हम किसी से भी सीख सकते हैं. So particularly for this particular thing, what is happening right now is we are losing the opportunity of training healthcare professional. We should actually this is also because of right now it's a problem on creating this quality culture. So there's a lack of SOPs for everything for us, how to ensure that surgical safety is ensured and other things. And we also are actually availability of trained quality professionals is definitely a challenge. Next slide, please. So what is the way forward here is we need to strengthen the first and foremost, we need to strengthen our reporting system. And as Madam has also emphasized, that implementation of non-punitive action for reporting error is very, very important. Because most of the time, the errors are usually, many of the nursing staff says कि बहुत consultant से बहुत डांट लगती है इसलिए हमने बताया नहीं. And they usually come up after 2-3 years कि ऐसा कुछ हो गया था. So that is also an thing we need to think about that. And sensitization of healthcare professional is very important. The day they are any healthcare professional, whether nursing or paramedic or MBBS student takes admission, it is actually the patient safety is not being taught, at least at present. The emphasis is not that much because patient safety is a priority. It cannot be chosen, or it cannot be it is actually mandatory, and the whole ethical principle of patient care is based on patient safety. So we need to sensitize. We say it, but we are actually, while talking also I was thinking, so we should include it as one of the important module, because we have few of the modules for our own undergraduate students here. Like communication is one important, we give a lot of time, but somehow we have missed. I think after this workshop and this webinar, at least because at our institute I definitely am going to have at least few lectures on patient safety, not just only a line of saying. So definitely we'll try to develop a module at our own institute. So sensitization is very important since they are actually the part of training process. And interdepartmental coordination is actually is a challenge also, and definitely we need to work, because most of the time when we have to, for any surveillance, like for IDSP also we take, so many of the time it happens कि पल्मो से नहीं मिल रहा, lab से नहीं मिल रहा, so that should not be a problem. That is actually opportunity to share and come up with a robust idea of what quality or what safety we are giving at the end of the day to our patients. So thank you very much. Next slide, please. So thank you very much to all of you. And I would like to acknowledge Dr. Archana ma'am for giving me the valuable inputs and to guide me also for patient safety. So thank you, everyone.
Thank you, Dr. Smita. And I hope everyone got a understanding of what the patient safety index, surveillance, and monitoring we are talking about. Uh, I'll just check that whether we have a questions or not. So don't have questions at present, but if anyone have any questions, they can definitely send to our email ID, and we'll get back to with the answers from the experts. As you very well said that we all are working in the silos, we do have indicators, but the future is of index, so we'll surely work on it.
Thank you, Dr. Archana. Thank you, Dr.
Yeah.
Smita. Thank you, everyone.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am, for your guidance. A special thank to Dr. Sujata Chaudhary, ma'am, additional DGHS, for her keynote address and continued guidance to the patient safety movement in India. We are grateful to Dr. Smita Sinha for her excellent care hospital, a topic that institutional accountability. We appreciate the participation of all our nodal officers, faculty members, and stakeholders. Your engagement is vital in taking forward the objective of the National Capacity Building Program on patient safety. We look forward to seeing you on again on 4th June for the next session on the scope of operational research in patient safety with expert from AIMS Jammu. Until then, thank you once again and stay committed to safe healthcare for all.